Overindulgence, stress, or the common cold. There are many causes and a variety of cures. Headaches, causes, effects, and treatments. Tonight, on Call with the Prairie Doc. Good evening and welcome to On Call with the Prairie Doc. Dr. Holm is off tonight. I'm Dr. Deborah Johnston with Avera Medical Group Brookings. According to the World Health Organization, headaches are extremely common. Nearly everyone has a headache occasionally. When they occur repeatedly, they are a symptom of a headache disorder. The most common headache disorder is tension-type headache. But first, let's take a look at this week's Prairie Doc quiz question. True or false? Headaches can be triggered by strong perfumes. Is that true or false? Viewers who call in the correct answer will be entered into a drawing to win a signed copy of the book, The Picture of Health. Each of Dr. Holm's essays, originally written for this show, comes with a wonderful accompanying photograph by Dr. Judith Peterson. We will announce the answer and the winner at the end of the show. Remember, you only have 10 minutes to get your answer in. We will answer your medical questions about headaches as they are called in or sent to us via Facebook or email. Call in questions to 1-888-376-6225 or send us an email to the address on the screen. Joining us tonight is Dr. Carol Nelson with Avera Medical Group Neurology in Sioux Falls, South Dakota. Welcome, Carol. It's great to have you here.
Thank you. I'm happy to be here.
Tell us a little bit about your background.
Well, I'm originally from Viborg, South Dakota, so a very small town. My father was a physician, and so I watched him, and I always thought that was what I wanted to be. And then as I got older, I thought, gosh, maybe I better see if that's really what I want to do, or if I am just, wanting to be what my dad was. And so I started working as a nurse's aide, and then, went to college, medical school, residency, and I did my medical school in Vermillion. At the time, it was the University of South Dakota School of Medicine, it was called then. And then I did my residency in Vermont. And then I came back to Sioux Falls in 1995, and I've been here since then.
And how did you decide on neurology?
Well, I did that by kind of finding the common thread in all of my preceptorships that I liked the best, which was always the neurology. I'd always came back to neurology. I did love neuroanatomy. That was my favorite class. But then as I went through all my different preceptorships, I decided that was what I wanted to do. And I'm very happy with my choice. I do really love neurology.
And now, you've specialized even a little bit further in neurology beyond just neurology as opposed to general practice.
Right. Well, in my residency, I was general neurology. I didn't do a fellowship after that, but when I came here, I was the only female neurologist in Sioux Falls, actually in the area. And I sort of naturally started getting more females. Headache is a little bit more common in females, so my practice just kind of gradually morphed over into being more and more headache. The more I did, the more I liked it. The more I liked it, the more I did. And so it just eventually became the majority of my practice, and I've been doing it for a long time now.
And you mentioned something a few minutes ago that I think is a really pertinent bit of information, that headaches are more common in women. Why is that?
Well, it's probably a few different influential factors, but it's probably primarily hormones. So boys and girls have about the same incidence of migraine until they hit puberty, and then the females go to about 3 times more common than the males. So the males kind of keep that plateau number or percentage, but the females sort of shoot off the charts at that point. So it's probably primarily hormonal.
Okay, yeah. And does that have implications for your treatment options?
I don't really treat the males and the females too differently during the reproductive years, and you've got to just be careful if there's a potential baby. You have to just be really careful about which medications you're choosing. But otherwise, no, the treatments would really be the same.
Okay. Let's talk a little bit about different types of headaches, because I think that there's a misconception out there that any bad headache is a migraine, or that somebody might not have a migraine when I really start talking with them and decide, you know what, I think you really do. So let's talk a little about those different types of headaches.
Yeah, you know what, I think it's surprising when you really visit with people that come in with a headache, how often it is really a migraine type headache. Mm-hmm. People in the general public tend to think of a migraine as really a severe headache, but some of them aren't that severe. So in general, they should be throbbing, one-sided, nausea, vomiting, light sensitive, sound sensitive, worse with activity, but you don't have to have all those criteria. So sometimes people will have a moderate headache and it's on both sides, but yet they're getting light sensitive and sound sensitive and nauseous. It still fulfills the criteria. And it's important to kind of differentiate what headache type you're dealing with, because of course that's going to direct what your treatment's going to be. Whereas, so the migraines tend to be the more severe ones. Tension headaches tend to be probably a little less severe, but they can hang in for a long period of time, so it sort of wears you down and therefore probably starts to feel worse over time. And then there's some other headaches that are less common, like a cluster headache, but those are like off the charts severe headaches, right? You can get headaches with a brain tumor. It's less common, that's what it is. More typically with a tumor, you're going to see other things like maybe numbness on one side of the body, or weakness, or something else, seizures, something else. So it's pretty uncommon for the presenting feature to be a headache. And then there's always, different bleeds that people could have, like a subarachnoid hemorrhage or something, and that's a headache that you don't have, and then all of a sudden it's a 10 out of 10, right? Mm-hmm.
Probably the thing that I see in my office most often are people who come in and they say, oh, I've got a sinus infection because I have a headache right here. And I talk to them for a little while, and no, I don't think you have a sinus infection. I think you have a migraine or some other kind of headache.
Yeah.
And I think that's a very common misconception.
It's actually, I've read that about 60 to 80% of sinus headaches in the general population, somebody calling it a sinus headache, not necessarily a physician, are actually migraines. And the reason is that the nerve that causes migraines it also innervates the sinuses. Mm-hmm. So not only is a sinus headache and a migraine in the same place, which is kind of right around the area of your eye, but you can also get some nasal stuffiness and clear nasal drainage as part of the migraine syndrome, which makes you think, oh, it's my allergies or it's my sinuses. I get a lot of referrals from the ear, nose, and throat once they've said, okay, the sinuses look good, but you've still got these severe headaches, and so a lot of sinus headaches I re-diagnose, and it's really commonly migraines. So I think that's a really good point.
Yeah, I think that's probably something that I see a lot as the primary care provider, because they don't usually go right to the neurologist when they think they've got a sinus problem.
Yeah, I doubt they probably ever do.
No, that's not usually where they go.
Yeah.
We do have a question, and I think this is a good one. It refers to something you and I were talking about a little earlier. An individual from Sioux Falls who wants to know about Botox and if it's safe.
So Botox is one of the proven treatments actually for migraine. It's one of the few drugs that's actually indicated as a direct treatment for migraine, right?
And that's an important thing to recognize. Like in so many things in medicine, a lot of what we do aren't formally approved to treat whatever problem it is that we're treating.
So we use them off-label.
We use them off-label, right. But Botox is actually approved.
Is approved, and I've been injecting Botox since we started using it therapeutically for migraine, because that was right about the time I was getting out of residency. So I started injecting I started in 1998 using Botox, and so and it's changed over time. We started with a really low dose. We started with about 50 units. Now we start with 155. It goes by units rather than milligrams, because it's a really small dose, because it is botulism. It's the toxin, and there's a set series that's been proven and studied. It's very safe. Every drug has side effects, and again, as we know from the word, it's a toxin. Right. So I do see people very rarely getting some pain at the back of their head, and I think that's primarily because I loosen some of the muscles back there, and other muscles have to kind of wake up and work a little bit
Compensate for
harder.
that.
If they get that, they'll have that for usually just a few days. There's been reports of kind of some general illness, like a flu-like symptom. And as far as I know, my patients haven't had that. They might, not necessarily tell me as long as it's mild. But for the most part, I don't hear side effects. And there's side effects to a lot of the medications that we use for prevention.
Absolutely.
So if I was going to pick just purely as far as side effects, I would probably, if it was me that was getting it, I would probably choose Botox.
How often do you see skin irritation or skin infections?
Not very often. I do get some bruising. If I happen to hit one of those little veins that I can't see, you can get some bruising. You're not supposed to give it if there's signs of infection in that area. But you can usually go around,
Right.
any little infected area. So no, I don't really see that as a problem.
Definitely something we're thinking about for those chronic migraine
Right.
sufferers. So, it's seldom that there's just one cause for a headache. Like much of life, it's complicated. So we had a question come in while we were listening to Becky's talk there. A woman from Harrisburg who wanted to talk about some home remedies for headaches, and I think that's a great question. So what are some options for people with headaches?
Well, what I always like to educate people is the things they can do to help avoid a headache, the things that they can do just in their life. So you want to eat on a regular schedule, don't skip breakfast, sleep on a regular schedule. So it's not just having 7 or 8 hours of sleep, it's actually getting to bed at the same time and getting up at the same time.
And not oversleeping.
Oversleeping or
one.
undersleeping,
Yep.
exactly. Both are bad. So keep a regular sleeping schedule, regular eating schedule, avoid foods with preservatives, minimize your caffeine, exercise regularly. And that doesn't mean like you need to go crazy or anything. If you're going for a 20-minute walk 3 times a week, that's a really good place to start. More is better. So all of those things can help avoid headaches.
Staying well hydrated.
Staying hydrated is really important, exactly. I don't know what they mean by home remedies exactly, but there are, of course, some over-the-counter medications that you can use. There's also a lot of talk recently about like the essential oils, and one of those that's actually been studied and proven is frankincense.
Really?
Yep. So that's one that I have learned about recently. So I think those kind of things can be
Topically,
good.
aerosolized.
They didn't say. This was at the
Okay.
American Headache Society meeting. But I know my patients have done it. Usually they'll rub it on their forehead. I don't know what it tastes like. I don't know if they can drink it or eat it. I don't know. I don't know what that smells like.
I don't think I do any of the essential oils internally.
Yeah, so that's one that's been proven, and in general, you want to avoid certain smells. So if you can avoid perfumes or potpourris or candles, kind of keep your environment as clean as you can in the home. As far as scents and smells, that's better as well.
I think one thing that's important to point out is with the over-the-counter remedies, you don't want to overdo those because you can get into that medication overuse headache situation. And if you're getting headaches, if you're using your medication more than a few times a week, then you really need to be coming in and talking with your doctor because you're running the risk of having the medication actually causing the headaches.
Exactly.
So,
and that used to be called withdrawal headaches. So
Yeah.
caffeine was kind of the famous one at that time, and then they changed it to rebound headaches, and then actually they changed the name to medication overuse headaches so that people know what they're doing. So just to kind of label it and let people know that
reinforce that.
Right. And
Yep.
so anytime you're taking a medication that you take at the time of the headache, or what we would call a symptomatic medication, if you're taking that more than 2 to 3 times per week every week, then you're at risk of this rebound or medication overuse headache. And a medication overuse headache, it tends to be all over. It's a dull headache that's there when you get up, and it kind of waxes and wanes through the day depending upon when you're taking your medications. But eventually you can have no headache-free time if you do that. So it's really important if you're using them on a regular basis that you go into your physician and see what are you doing, are there triggers, or do you need a preventive medication, or
and what type of headache is this? Is this
Exactly.
something else that you should be doing? One treatment that I find is often underappreciated is ice. Ice or heat, those physical modalities. There are a few situations where that might not be safe for somebody, but it's pretty rare for
that's
that
a
not
really
to be
good place
safe.
to start, though.
Yeah,
Right.
for a home remedy. So I want to point out to everybody, this is your show. Your questions are key to our discussion. So call in your questions about headaches to 1-888-376-6225 or send us an email to ask@prairiedoc.org. So that question about home remedies, I think everybody who has headaches is probably familiar with Imitrex, which was really revolutionary when it came out.
Right.
What is it, 25 years ago now?
Actually, that was in about 1994.
Okay.
I was in residency at the time, so
Yeah.
I remember when that came out, and it really changed how we treated headaches.
Yes, it changed
Right.
people's lives
Right.
in a major way. And now, of course, it's got several sibling drugs that are available
Right.
out there. So are there any newer things out there for headaches?
Well, there Botox is probably the newest thing that has come out, and that was actually quite a few years ago. There's another drug that is just right on the cusp. We're just waiting for it. It's got a totally different mechanism of action. I don't know too much about it yet because we don't know a name, we don't know how it's given, we don't know a dose. You know, we'll find that out with everybody else on the Today Show. Right. But there is some really exciting headache research. There's also some research that we've done through our office that I know you're familiar with on headaches called eye grains that have to do with how your eyes work together. And an optometrist in Mitchell has developed some patented lenses that help your eyes work together and avoid that particular headache type. So that's some exciting research too, and that's something that's not a medication, which is nice to have something that's not a medication option.
Speaking of non-medication options, what has your experience been with the, what is it called, Cephally? It's the little TENS unit.
Right, so that's the Cephally device. And it is a TENS unit, and it's put right on your forehead, which is sort of one of the endpoints of migraine. It's that same nerve, which is called the trigeminal nerve. So it's it kind of looks like you took some glasses and put them up on your forehead. It's sort of like a headband. And there's a sticker, so it sticks there. And actually, there's a new unit that came out that's very small, like the size of a 50-cent piece or a little bit smaller. And so with a sticker, it goes just right on your head. And I've had kind of mixed results with it. I think that's for a little bit of a milder migraineur. It's for preventive therapy, so you use it for 20 minutes each day. So I've had a few patients use it. Again, something that's not a medication, good for people that are intolerant to medications, good for people that are pregnant, somebody that can't take, or maybe even somebody younger that can't tolerate medications as well, potentially.
Interesting. Interesting. The things that
there's actually some other newer ones. So that one goes at the front of your head, but there's something called an STMS device that is it's like a little pop of it's not really like an electric shock, but it's a thing that you hold on the back of your head, and it gives you these little pulses, and that's, it sounds kind of quirky, but that's actually proven too, and so that's something that's just come out. We'll see how that works. The studies look good. It's fairly expensive because it's new, so I think that might be a limiter, but there are a few things that are coming down the pike, which is nice because we haven't had anything new for a while.
Talk to me about massage and headaches. What do you see the role of getting massages for people with headaches?
Well, I think massage is good for a couple of reasons. It does cause some stress relief, which is helpful because I mentioned that's a trigger. But when people get migraines, because of this trigeminal nerve being involved and where that comes from in the brainstem, it actually activates into your neck. So a lot of people with migraines, about 80%, before, during, or after a headache, a migraine, are going to have neck pain as part of their syndrome. So when that migraine is activated, it activates your brainstem and into your neck and causes that tightness in your neck and shoulders. Getting the massage can loosen that up. Now, it doesn't get to the underlying mechanism of the headache, but it gets to kind of the end point where you can relax your muscles and just kind of more for symptomatic relief. So that's a good option.
Good. Here came in a question about some different types of headaches that people might experience. Besides, we've spent a lot of time talking about migraines, which are certainly one of the most common type of headaches that people come to care for, but this question was about a post-concussive headache. So the question had to do with how long people could expect to experience headache after a concussion, and specifically an elderly lady who hadn't had headaches before her concussion, and now after a fall and a concussion, she's getting headaches.
Well, there's a few pieces to that. So when like if a person with migraines has a concussion, it can often exacerbate their headaches. Now, somebody who hasn't had migraines by this point, they're certainly not a migraine person. So when you get a concussion, you tend to get more of a generalized headache, or else it hurts kind of right where you hit your head. So it tends to be a slightly duller pain than, say, a migraine would be, potentially sharp and throbbing, but they can really hang in there. And if you read about it, they're going to talk mostly about a 2-week headache. I see it a lot longer than that. And it has to do with a few factors. One is that, it causes the headache just from that jarring of the brain and the change in the neurochemicals in your brain. But especially somebody that's older, they hurt for other reasons. As they're falling, they can tighten up. When they hit, they tighten up. So there's a lot of muscular component to it and probably some bone component to it. So the pain's coming from different sources. So to say a definite time that it would last is really hard without knowing the whole story, because it depends on so many factors. But if you just looked it up, you're going to see 2 weeks. But I see it a lot lasting much longer than that.
Yeah, I do too. And obviously my patient population is not usually as intractable as yours.
Right,
so.
right.
One other question that refers back a little bit to what you had mentioned a little bit before, a man from Sioux Falls who had some questions about glasses or not having glasses and whether this could cause migraines. And in his individual case, his headache was localized behind his left eye, and would glasses or contacts help alleviate his headaches?
So I always like my patients to get their eyes checked every year. If you're struggling to see close or at a distance, there's going to be eye strain. There's so much connection between your eyes and how they move together and how they see, your visual acuity or clarity, and your brain, that you really want to be able to see well and get your glasses adjusted to the right prescription to make sure that you're not putting more strain on your eyes and your brain. The migraines tend to be right behind one eye. So the fact that he has pain behind one eye, it's probably a migraine. So you probably need more than glasses alone. But I really try to preach to my patients to get into their eye doctor and make sure that they're taking away that component, that eye strain component of it. But somebody with headaches behind one eye, it's more likely a migraine, and that's probably not going to be the sort of easier option, right?
Yeah, and that's a fairly classic thing, is that headache there or there, and the teeth hurting is such a common complaint for people. So. Tell us a little bit about the aura that some people experience with migraine, because I think that's something that a lot of people in the general public underappreciate.
So an aura is actually present only in about 20% of migraine patients. So that's why it used to be called the classic migraine. Now we call it migraine with aura, because it was kind of sort of considered that's what a migraine is. So there's different types of aura. So there's the visual aura, which tends to be, it can be those little shimmering lights that kind of tend to be on the outside. It can be black spots that move around and actually can be very disabling when somebody's trying to work and they've got this black spot they're trying to read around. So there's the different visual aura. It might be a really bright flashing light. It's really common for the person's visual aura to be the same every time. So you might have a visual aura. You might have numbness on one side of the body or the other. Some people, much less commonly, will have trouble with their speech. Like not just a little bit of concentration trouble and trouble coming up with the words, maybe can't remember that name, but much more pronounced than that. And a really quite rare headache type is called a hemiplegic migraine, which is actually a migraine with aura, but the aura is actually a weakness, like they had a stroke on one side. So that's important to differentiate that type. That person definitely needs an MRI and some workup, make sure they don't have stroke risk factors. But those are all auras. Auras tend to last about 20 or 30 minutes. If they're lasting more than 2 hours, it starts to get a little worrisome. Now that doesn't mean the visual aura that comes and goes over a whole day, but each time you have it, it should be less than 2 hours.
Very interesting.
Yeah.
It's interesting what the brain can do.
It is amazing.
Sometimes it's hard to tell if as a new pain presents, if it's acute or chronic, but it's an important distinction for the patient.
Chronic pain is defined as pain of greater than 6 months duration, and acute pain is pain of less than 6 months duration that we assume will have an end point and will go away. When it doesn't, acute pain can then become chronic pain. Acute and chronic pain are, if undiagnosed, are treated the same. Pain is a protective mechanism of the body when the body's injured or there's something wrong, and you should always first evaluate for potential serious causes, fractures or tumors or blood vessels that aren't growing in the correct place, and rule out those kind of tragic or catastrophic possibilities before you start to treat the pain. Chronic pain has a lot of different causes. It also has a different impact on each patient's lives. We see a significant amount of anxiety and depression that goes along with chronic pain. We also see a lot of chronic pain in patients with primary anxiety and depression. So making sure that we address the behavioral health side of chronic pain management is very important, and sometimes those people will need a little more access to the healthcare system than others. Treatments for pain that range from a new exercise regimen to a short-term prescription regimen to a surgical procedure, depending on the cause. And that's where the diagnostic part of it is very important, to isolate the specific cause. And when there's no cause identified, that's probably when we struggle the most in overall treatment. Be patient. The medical world right now is going through a huge change in their philosophical approach to pain management. So in this day and age, we're trying to find causes to the pain. We're trying to find non-medication management strategies to deal with it. And as far as non-cancer pain goes, we've really changed our approach with the narcotic medications, and that we're limiting them. And that may be their primary care provider, physical therapists, chiropractors, psychologists, nutritionists. There's a wide variety of people that can contribute to treatment of chronic pain.
So we had a very interesting question come in here, and this is something I hadn't considered before, but has migraine ever been considered an autoimmune disease?
That's a good question. I've never heard that it is. There's a lot of different theories still. You know, the mechanism of migraine has changed over
Since we
my
were in
career
medical school.
and probably
Yeah.
yours. Yeah. You're younger than me, but probably
Not
over yours
much.
as well. But I've never, I think that's a really interesting question, an interesting thought, but to date, there's nothing really revolving around the autoimmune component of it.
It is interesting because we see migraines more commonly in women. We see autoimmune diseases more commonly in women. And maybe in 20 years, our successors will be sitting here talking about how it is an autoimmune disease. Who knows? Interesting question. And here's another one that I think is also an interesting, I think this is a good thing to talk about because I think it plays into some of those other types of headaches that we haven't talked very much about. But this individual gets a headache every week. It's a very instant headache, lasts only a few minutes. They had an x-ray done, but nothing was found. And what would some potential causes for that headache be?
So that type of headache, it's probably, there's different names of it. It can be called an exertional headache, a thunderclap headache. Those headaches come on really suddenly, they peak really quickly, and then they're gone really quickly. And then they can linger with a little bit of a dull pain though. So the first thing you want to do is rule out an aneurysm. Mm-hmm. Now, people that have had several of these, it's probably not an aneurysm, but I always like to get that just to kind of rule that out, and so that I can concentrate on the treatment. So,
particularly if it's not something they've been getting for 20 years
exactly.
or 5 years.
Yeah. So that headache type is a little bit less common, but it's not that rare. We do see it a fair amount. Another headache in that same category is called a primary stabbing headache, which used to be called an ice pick headache, which I like that name better because it's very descriptive. And so that tends to be a headache that's in a very kind of a small area, but it's just really sharp and just it'll last a few seconds and almost drop you to your knees type pain, and you think, gosh, if that was any longer, I wouldn't really be able to stand that. So that headache type is one that doesn't necessarily respond to over-the-counters, and they're so short. By the time you find your medicine, it's gone anyway. But it's common for you to get more than one in a day. So I usually have people treat with like an over-the-counter ibuprofen, Aleve, one of those, because they're more likely to get some later in that day as well. Now, sometimes they won't respond to those and you need Indocin or indomethacin. They're also called indomethacin responsive headache because they respond to that particular medication. So indomethacin is also a non-steroidal anti-inflammatory drug, so in that same kind of category as ibuprofen and Aleve, but this particular headache type is more specific in that it really likes that one.
And the only other thing we really use that for very frequently is gout.
Right, exactly.
Yeah.
Yep.
Not something you usually treat.
And it's hard to, no, never. But it's hard to take that medicine because
very
it does
hard on
hurt
the
your
stomach.
stomach.
Yeah. Yeah, it is very hard on the stomach. The other thing I think of when I read that question is occipital neuralgia or trigeminal neuralgia, or those kinds of short, stabbing, doesn't last very long, but really intense kinds of headaches.
So a trigeminal neuralgia you've heard me say the trigeminal nerve a few times as far as migraine, but that usually involves the top couple of divisions. The trigeminal neuralgia is more common, like through the cheek area or down into the chin, and that's a lancinating, electric, sharp, severe pain. So if it's more in your face than in your head, then I would definitely be thinking about a trigeminal
that
neuralgia.
Kind of thing.
Yeah.
Yep. So, and this was a question that I thought was, it kind of plays into a little bit of what we were talking about. I don't know if this individual had called in before or after, but this individual's 26-year-old daughter had had a history of terrible migraines and got those neuro lenses, the iGrain lenses that we were talking about, and found significant migraine relief, and they were asking what your opinion of those lenses was.
Well, I have a good opinion of those because I'm part of that research. So I've seen a lot of really just miraculous assistance in the headaches from the neural lenses. So that's not actually a migraine, so it's a little bit different. So the iGrain has to do with how your eyes work together. And since each eye can see, when you open both of your eyes, the images have to match up perfectly. I mean, like a mirror image of each other, or your brain doesn't like it to be off slightly. So then all day, no matter where you're looking, your brain is trying to keep those images matched up. And so you see okay, but your brain is basically in overdrive. Right. And so there's a measurement that we do with a sight sync test that measures how your eyes work together. And it's not like they're way off. Like, you and I would see patients that have double vision and they're pretty far off. This is like not something that you can just see by looking at somebody. And out of that sight sync measurement, you get a prescription for the neural lenses. So it's a patented progressive prism lens, so that you've got the right amount of prism no matter where you're looking, whether you're looking at a distance or close. And it basically keeps your eyes in sync so that you're not putting that trigeminal nerve into overdrive. So iGrains are a little bit different. They're more of a bilateral headache, very commonly at the back as opposed to the front. They're worse with reading and working on the computer, and when you have that, you also tend to get sleepy when you're reading or working on the computer, and sometimes dry eyes. So you get this measurement, you wear the neural lenses, you wear those, for the most part you wear them all the time. Some people can get away with wearing them just with reading and working on the computer. And it basically takes that strain or that stressor off your brain needing to coordinate those eye movements. And when it does that, and it's backing off basically from that trigeminal nerve, it can actually help your migraines as well. Okay. So it's not indicated for migraine, but when you get rid of the iGrain component, you don't have that feed right into your migraine as well.
It's lowering that high jump bar again, or raising it, however you want to say it. So is there would something like wearing a patch give somebody an idea if that might be something that would be helpful to them? Or
that's a great question, and that's actually one of the ways we test for it. It's hard to do because you would need to wear the patch for a while, and of course you lose your depth perception. So, but if you wanted to try it and see if you potentially have that, since it has to do with how your eyes coordinate together, you can patch one eye. And then if your headaches go away, that's what it is.
How long
Yeah.
would you need to do that to make it a fair trial?
You'd want to do it for several hours. We recommend people do it for 3 days.
Okay.
And that's why it gets so tricky. But if you could do it the whole weekend, that's ideal. Some people can tell right away. They can tell after a couple of hours, and then they take the patch off and they feel this pull or this strain.
Come back. Interesting.
But you can do that, or you can get the site sync testing. So that's an easier way to do it.
yeah. But maybe a little more time involved than just patching your eye for a weekend.
Exactly.
And then
Yeah.
you'd know that, gee, this is probably going to be really helpful.
Right.
So, all right. Here's a question that I think is, again, refers back to how things have changed since you and I went through medical school. Is migraine mostly vascular or neurological? And does a hot or cold shower help?
Well, right. We used to think that that migraine was vascular. That was based
That
on
was what
the
we were
theory.
taught.
Right. That's based on a theory from Dr. Wolfe, who was a famous headache specialist, and that theory was that you would get some constriction of your vessels and then dilation, and that dilation was that throbbing type pain. What we've learned over the years, as in medicine all the time, your theories kind of morph over time as we have more
Learn
research,
more.
right, and have better testing, that it actually has to do with the change in the chemicals in your brain, and several of them. It has to do with dopamine and serotonin, which are probably the most commonly discussed in the headache realm, but also somewhat epinephrine and norepinephrine. Now there's something called CGRP, which is another receptor that is responsible for headaches, and that's actually what that new drug is targeting that we were talking about earlier.
And these are chemical messengers, basically,
They're
is the way
all-
I describe them
right.
to people. Your brain cells use these to talk to each other.
Exactly. And so I think with that question asking if it's neurologic, I think that's probably what they mean by that. I would say instead of being a vascular thing, it's more of a biochemical thing. And when those chemicals change in your brain, it actually causes your vessels to change a little bit, but that's actually not what's causing the pain.
It's the
just
side
part of
effect.
the syndrome. Exactly. It's just part of the whole syndrome.
And do you usually find cold or hot more effective, or is it person dependent?
I've seen both. It's very person dependent. Back on that Wolfe theory, when you would get the vasodilation of your vessels as the presumed theory, part of that came from people getting in hot tubs, and your vessels dilate so you can get more blood out to your extremities to kind of dissipate that heat, and that would set off migraines for people. So that's kind of one of the ways that theory came to be. So in some patients, yes, it will get worse if you take a hot bath, but in some patients from the relaxation and whatever, they do better. So you have to find what works for you.
This is I think, very related, very important, interesting question. A woman from Rapid City who wants to know if GI symptoms like IBS or nausea and vomiting are common with migraines.
Well, those are common. It's actually part of the diagnosis is to have the nausea and vomiting. And it's really, when we're talking about these chemicals or these neurotransmitters, one of the neurotransmitters responsible for migraine is serotonin. Well, that's the neurotransmitter responsible for how things happen in the gut. And so there's a really strong connection between the gut and the head. And so there's a strong correlation between headache problems and stomach problems. I don't know if it's definitely something with the migraine makes them more prone to IBS. I do see more patients that have the irritable bowel syndrome that also have headache, but I don't know if it's two common things that are both coming
Common things
together.
happening
right.
commonly.
But there's certainly
Yeah.
a connection with the brain and the neurotransmitters and the gut and what happens there.
Yeah. And of course, the vomiting is such a common problem
Exactly.
with the migraines. So,
The vomiting can be a disabling part because it's hard to stay at work, if the nausea and vomiting is that bad.
right, even if you can concentrate through the headache.
Exactly.
Yeah. I'm not quite sure exactly what they mean with this next question. What are the causes and treatments of ocular migraine with ruptured vision? I suspect it might have to do with the migraine with just the aura where you don't get the headache after?
So the ocular migraine is also one of those older terms that we now would call migraine with aura. So some people will get the ocular migraine or the aura, but not get the headache. So they might get those shimmering lights or the black spots or colored flashing lights, or sometimes they'll lose half of their vision in each eye, and sometimes they won't get the headache. So I'm not sure if that's maybe even what they're talking about, but there's still, the mechanism of that is still the change in the neurotransmitters, and therefore the treatment is really the same. Now the tricky part, if you just have the aura, is it oftentimes is going to be gone in 20 minutes. And so it's hard to treat it. By the time you find your medicine, take it, it gets absorbed, the aura is going to be gone already. Anyway. So if somebody is having a really frequent aura and it's getting in the way of their work or they're driving, sometimes I'll add a prevention medicine because you just can't treat it at the time, it's too short.
And it's, as a primary care person, I think it's also really important to say that if you're getting these symptoms, you need to get to the eye doctor and make sure that it's not something going on in your retina, that you're not having a detached retina or some other injury to the eye. So here's another question that I think gets into some of those non-medicine treatment options. A woman from Aberdeen wanting to know if hypnosis might be helpful in migraine treatment, and if you're aware of anybody in the area who might do that.
I don't know of anybody in the area that's doing that. I think all of those things have to do really with how you're coping or managing your migraines. And I think anything that is going to work for you, especially things that are not a medicine, are good. Because the more you can bring your headaches down in number, you're going to have to use fewer headache medications at the time. And so that's going to help you avoid rebound headaches. So I'm not aware of any specific research with hypnosis, and I haven't had a lot of patients tell me that they've done it, so I don't know that I can give a great answer on that. But anything that's going to bring your headaches down I'm all for it.
I also think that it kind of plays into some of the biofeedback, the cognitive behavioral therapy.
Right.
I mean, I think that there's a lot of non-prescription, non-medication, non-drug things that you can do to manage your headaches, and a lot of the chronic pain programs available that are good for all kinds of different pain, not just headaches, but fibromyalgia and rheumatoid arthritis, and all of those things can really involve that, and in a way hypnosis plays into that same kind of thing. So.
And I think, along that same line, acupuncture. Yes. I've had a lot of patients have really good luck with acupuncture. Yes. But I think any patient that's going to go to a counselor and get some stress management techniques, anything they can do to help with the coping during a headache, because when you start to get a headache, everything kind of ramps up. So your heart rate goes up, you kind of get in that fight or flight mode, which makes you more responsive to pain in a bad way. So if somebody can help you, like when the headache comes on, keep all of those things to a minimum, it's going to decrease the pain from really ramping up. So any of those things are really great options.
Definitely worth pursuing. So here's a question that doesn't quite relate to headaches, but a question about more general neurology. If you had a concussion and a minor bleed, how long should you wait before you fly?
Ooh, that's a question for a neurosurgeon. Neurologists don't actually do a lot with the bleeds unless it's, the real small ones from high blood pressure. I'm not going to answer that. I don't want to accidentally give the wrong answer.
That's a fair response.
Too far out of my field.
We'll turf it to the neurosurgeon that should have was probably consulted if they had a bleed.
Yes.
And an individual wanting to know, intrigued by those neural lenses, where can they get them?
So there's a couple of places, there's a few places now that you can get them. Sioux Falls Family Vision, you can. There's one of the doctors, an optometrist, Dr. Ackerman, that does them, so he's a great one to look up. Those are both in Sioux Falls. There's Dr. Jeff Krall and Dr. Joe Krall in Mitchell. And Dr. Jeff Kroll is actually the inventor. His father sort of started it originally, and Dr. Jeff Kroll invented the SightSync machine and patented those lenses. So if you're close by Mitchell, that's a great place to go. But Dr. Kroll and Dr. Ackerman have a huge amount of experience. But like I said, Sioux Falls Family Vision does it as well.
And how is the insurance coverage for that?
Insurance doesn't cover it. Like your eye exam could potentially be covered if you have eye insurance, and potentially the frames. But when this first came out, it was a pretty expensive treatment. It was in the thousands with the new research and the development of the machine, right, and the studies and stuff. So that has come way down, and it's a little bit different depending upon where you go, but it's anywhere between about 600 and probably, I think, around 900, depending upon if you need, progressive prism or how bad your prescription is. But the price has come way down, really much down into where people can, more reasonably trial them, right?
And now, for the winner of tonight's Prairie Doc quiz question, which was a true or false question. Headaches can be triggered by strong perfumes. Was that true or false? And the answer is true. It was Larry Wars from Pierce, South Dakota, who answered the question correctly. Thank you, Larry, for participating, and a book will be in the mail to you soon. We'll be right back after this.
All around town, from stores to playgrounds, babies are on the move. And there are diseases that are on the move too. And some of these spread easily. To best protect him from 14 serious diseases by the time he turns 2 years old, vaccinate him according to the recommended schedule, so he can go on about his business and you can have peace of mind. For more reasons to vaccinate, talk to your child's doctor or go to cdc.gov/vaccines.
Headaches are an age-old ailment. In fact, written descriptions date back to the ancient Mesopotamians and Egyptians, where they were attributed to curses from demons or to imbalances in the body's digestive system. Suggested remedies ranged from incantations meant to enlist the aid of the gods to topical poultices made from a variety of often unsavory substances. In later centuries, attempts to obtain relief might involve shocks from electric ray fish, or even inflicting physical damage to the scalp and skull. Headaches may be generally invisible to the outside observer, but the suffering they inflict is nevertheless very real. People call in sick, or show up to work unable to concentrate, or stay home from social and family events they want to attend. The annual financial burden is in the billions of dollars. And how can you quantify the personal cost to individuals and families? Almost universally, when patients show up in my office suffering headaches, they want two things. First, relief from their suffering. Second, relief from the fear that the pain they are experiencing may represent some terrible disease that will threaten their future, such as cancer or a stroke. Happily, only a minority of headaches are a symptom of some ominous underlying problem. In most instances, the key to understanding a person's headache lies in understanding its pattern. When does it strike? How does it develop? What influences the pain for better or for worse? Only rarely do CT scans or MRIs or lab work contribute to the diagnosis. As with so many things in medicine, having the time to ask the right questions and to listen carefully to the answers is irreplaceable. Headaches can't yet be captured by technology. Our options for bringing relief, though, have come a long way from the days of our ancestors. We have preventative treatments to reduce the frequency of attacks and targeted therapies to interrupt them once they start. This often incorporates medications originally intended to treat other ailments and some designed specifically to treat headaches. It might include biofeedback or cognitive behavioral therapy or physical therapy or acupuncture or massage. We often recommend changes in diet exercise and sleep habits. Sometimes we even use electricity, although today's delivery system is a bit more sophisticated than what the ancient Romans had available. After 6,000 years, we are getting closer to conquering headaches. Modern medicine can offer hope for an improved quality of life. A big thank you to our guest, Carol Nelson, tonight. Your experience brought great insight to our discussion.
Thanks for having me.
That does it for us tonight. From all of us here on Call with the Prairie Doc, until next time, stay healthy out there, people.
We open our phone lines and email to any medical question you may have. It is our first Ask Anything of the season. Next time on Call with the Prairie Doc.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call Television as it continues to open doors for important medical information.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota, and with the ongoing support of these individuals and institutions: Brookings Health System, Ophthalmology Limited, South Dakota State Medical Association, Avera Heart Hospital, Dakota Allergy and Asthma, Fishback Financial Corporation, Vance Thompson Vision, Aberdeen Asthma and Allergy, Aberdeen District Medical Society, Black Hills Medical Society, Dakota Bank, Orthopedic Institute, Physicians Care Sanford Clinic Community Service Committee, and Swiftel Communications.